Good day, everybody. Hello and welcome. My name is David Levy. I'm the CEO for EHE Health. Thank you all for joining us today. We are going to have a very interesting deep dive on the impact of COVID-19 on maintenance and preventive healthcare and what has happened across the country as a result of this pandemic. For those of you who were on our last webcast a few weeks ago, which really were the origins of this webcast, at that time we talked about the comorbidities of COVID-19 and what we could do as employers immediately to reduce the impact by addressing those vulnerable people and getting them in for treatment. At that time, we were joined by Craig Kurtzweil, who leads the Center for Advanced Analytics at UnitedHealth Group. He focuses on data that drives insights and innovation in the ways and the way UnitedHealth Group delivers value for their clients. Well, he showed us some incredibly interesting data, and we asked him to spend a couple of weeks digging in a little bit deeper into that particular topic to see really what has happened with respect to preventive and maintenance care in America. And today he's rejoined us, thank you, Craig, to help us look at this topic in depth. As many of you know, I'm an epidemiologist by training. We're often referred to as disease detectives, not just because it's easier to pronounce, but it's also to avoid confusion with dermatologists. But it's because we're trained to search for the cause of disease, identify people who are most at risk, and to find ways to control or stop or prevent diseases from happening again. When we looked originally a few weeks ago at some of the data that Craig showed us and what we are going to see today, becomes and should become obvious to most that once this epidemic is over, we are potentially looking at another big problem, which is a buildup of lack of preventive health maintenance for many, many, many Americans, and potentially another big problem in the years 2021, 2022 with respect to a resurgence of cardiovascular illness, cancer, and immunization preventable diseases. So that's what we're going to talk about today, but I really don't want to move ahead without acknowledging that just a couple of days ago, our country has passed really a horrific milestone of 200,000 deaths due to COVID-19. It is an almost unbelievable situation, and all of us feel strongly for those who have suffered, those people who have lost loved ones, family and friends, and people who have been hurt by this illness. And it's important to recognize that we are still in the throes of this pandemic here in America. Special recognition obviously goes to all the essential workers, in particular healthcare workers at the front line who are dealing with this every day. So we thank and we recognize and thank all of them. And so while today we're going to be talking about what happens after this pandemic, we are still in the middle of it. And as we all know, some of the data suggests that we're on the uptick again. And if there's one thing I can say and can't say strongly enough, is that public health works, masks, social distancing, quarantine, contact tracing, those are the public health, what I call the public health 101 tactics that can really help us contain as we go into the winter, the fall and the winter season. So let's just today move ahead and look at what Craig is going to discuss with us, and now advance our minds and think about really what happens after we emerge through the back end of this epidemic, and what we should be on guard for, and what we should potentially prepare for over in the medium term. As usual, we will be taking questions. We hope this presentation will be about 20 to 25 minutes. The discussion is usually robust. Just ask questions on Zoom and I will take them and answer them, and I'll either answer them personally or direct them to Craig. Of note is this time we have some media present on this webcast. So for those of you who wish to remain anonymous for any questions, that's no problem at all. Just submit the questions anonymously. So with that said, welcome, Craig. We're looking forward to your presentation, and I'll advance the slides. Thank you.
All right, thank you, David, and thanks for having me back. It's always nice. As a data guy, it's nice to get an audience to be able to talk through what we're seeing in the healthcare spectrum. I'll spend some time, as David mentioned last time I spoke to you, we talked at a very, very high level around some of the ripple effect that COVID is going to have on our society from a healthcare perspective in 2020 and beyond. And so rather than focus on the ins and outs of COVID and the different waves and the trends, we'll focus on that and what is the underlying maybe less talked about impact that COVID is going to potentially have in society. And I think a call to action around something that we all can do to help improve and focus and guide members towards these choices that we think will impact the healthcare system going forward. So let's move forward to our first slide, David. So as we jump in and think about what is going to happen to the U.S. healthcare system beyond just the impact of the disease itself, I bucketed it into two different categories, and we'll hit on a lot of these during our discussion today. So we have tailwinds. There's going to be some things that even with the loss of life and the major issues that we definitely face with COVID as a disease, there's going to be things that as a society from a healthcare system that we're going to learn, that we're going to improve upon, and that hopefully will better equip us if we're ever put into these kind of circumstances again. So for example, one of the big changes that we've experienced that we think is going to be a longer term sort of win is the transition into telehealth. We all knew that telehealth was coming. Maybe it was 3-5 years ahead of us. But with COVID coming in early 2020, we definitely ramped things up really quickly as a healthcare system. We saw substantial upticks in telehealth utilization, 200, 300, 400% increases in normal everyday providers leveraging telehealth to talk with their patients, going beyond just members using national telehealth vendors to determine if they need to go to an ER or not, taking telehealth to a whole nother level. What I would say is that we saw a definite peak in the early March and April and even May time periods. That has come down in the last few months. We started to normalize a bit. So where do we end up as a healthcare system? Is the peak sustainable? Probably not. That was probably really a direct response to the barriers we faced to care at that time. But the old way of doing things is probably no longer the way we go forward. There's going to be a potential substantial portion of the healthcare system that migrates into leveraging telehealth where it makes sense for the provider and it makes sense for the member. So definitely some benefits there. We definitely are changing as a society when it comes to just broad personal hygiene. As David mentioned, washing our hands, wearing a mask where appropriate. Those kinds of things are probably going to make a long-term issue, a long-term change in our healthcare system, not across multiple different generations. Think of the younger folks that are growing up in a society where that is a focus, a requirement. Is going to be really interesting to see how that continues on when COVID, knock on wood, hopefully is behind us. And then infectious disease protocols. Think about how we handle the flu or other potential infectious diseases that are out there. Historically, we didn't really do a lot. If you were sick, you stayed home from school, hopefully. You'd see some of those communications. But as a healthcare system, we're learning to protect the high risk, protect the elderly, separate folks that potentially have infectious disease or have been exposed to infectious disease from those populations that could be impacted most greatly. So think about how we handle the flu. Is there going to be a change in how the healthcare system handles somebody that's going in to a normal office visit to see if they have the flu? I think a lot of that changes dramatically. And then we have headwinds, and we're going to focus on these today. So preventive care, as we talked about last time, definite impact, severe impact to preventive care utilization during the heart of COVID. We'll talk about some of the timeframes and where that is today, but that'll be the focus of our discussion here. And then we'll focus on the return to health or the return to preventive care. Do we start to see a bounce back? Do people just suddenly go back to the doctor and get preventive care done? I think there are obviously legitimate barriers to that, as some offices are still not open to the extent that they were historically. And a lot of members legitimately are high risk and are trying to avoid some of those settings as much as they can. But I think psychologically, this is going to be a big undertaking for America and maybe the world as we go forward, because as we start to analyze the preventive care gap we typically rely on things like what happens when a hurricane strikes, what happens when we see wildfires, those types of things in a healthcare system. And we analyze those and we see a tremendous dip in care as people spread out and don't have access to care. But we see those people come back pretty quickly and pretty rapidly, and we catch up as a society from those kind of events. But COVID has created a whole different psychological barrier where now we're actually, some portions of the population are now afraid to go to the doctor. Not only do they are maybe uncomfortable with it, they're legitimately afraid of that as a risk perspective. How do we overcome that, and how do we overcome some of those barriers? And then disparities. We'll talk about that here. Obviously, a real impact what we see across the U.S. healthcare system historically. COVID has shined a light on it even further. From exposure to COVID, mortality to COVID, all of those things is a separate conversation. But likewise, when it comes to barriers to preventive care and reductions in care, we're seeing that it's not a one-size-fits-all sort of impact. It's different, impacting different populations to different extremes. Well, let's jump in. Let's look at some data. So just to kind of recap, this is some of the views that we saw last time I was here, just at a high level. We'll do a double click into each one, a couple of these different areas. But during the COVID season, so this is looking at basically March through July, we are seeing that all of these preventive services are seeing dramatic reductions. So of the people that should be having these procedures done, we're seeing, for example, on the far left, chickenpox vaccinations in youth, we're seeing that reduced 24% compared to what those levels were in 2019 during the same time period. Wellness visits, 30% reduction. We go to the far right, we see all the cancer screenings, cervical, breast, colon. We see 50+% reductions in those screenings occurring across America. And again, focused on populations that should be having those done. So 50+-year-old women and those types of parameters are part of this. In the middle, we have some chronic disease measures. So cholesterol screening, diabetic glucose screenings, hemoglobin A1C test draws. We're seeing those in the 30 to 40% reduction. Just dramatic shifts in leveraging preventive care during this time period. What we're also starting to see, I mentioned, as we analyze hurricanes and natural disasters such as that, we see a sharp decline and we see a sharp increase. We do, in those types of disasters, do see that there is some utilization that never comes back. It's a smaller portion, but some of that utilization never comes back just due to a timing effect. What we're seeing so far from COVID is these kind of trends were definitely more dramatic in the March, April, May time period. But what I would say is as we get into June, July, August, and September, we are seeing these start to approach normal, but we haven't yet seen a catch-up period as everyone kind of expected. Once the offices opened back up, people got back to what those levels were looking like in 2019, but we have not seen those levels go above 2019 so that we start to catch up and fill in for the gap that we saw during those critical 3 months in the early COVID season. So keep that in mind as we kind of walk through some of this analysis. I'll take some of those stats and we'll focus in on wellness utilization first of all and start to break it out, because as we know, if we learn anything from COVID, it's definitely not one size fits all. It's impacting different geographies, it's impacting different ages, different ethnicities, different income bands, and so on very differently. And likewise, abatement or the reduction of medical utilization specific to wellness is different for these different populations. So for example, as you look on this slide and look at the different age bands, so the far left is going to be some of the infants and kids, and then on the far right is going to be some of the older population, the 70+, 80+ population. What you see is across the board, everyone's reduced 20+% for wellness utilization. And remember, it was 30% for everybody. So keep that as a benchmark. That middle bucket, the 25 to 50-year-old population, that's where we're seeing the most substantial decline in preventive care. A population that's now seeing about a 40% reduction in people going in for a wellness visit during this time period. They might catch up, they might come back in the fall, but a big hole to come back from, a big deficit to try and rectify for the second half of the year. As you see, as you start to split this data, you can go ahead, David, let's go. As you see this data split by gender, As we all know, the male population, I'll fall on the sword. We do a really poor job of preventive care and wellness to begin with. So we're starting from a deficit, and COVID hasn't helped that. The abatement of services has impacted the male population slightly more. You can see the numbers are fairly close, 28% reduction for female, 30% reduction for male. But just note, men were roughly about half as likely to use wellness preventive services as females. And this is just added to that gap between the genders. As we look at this by income, we use some logic to determine an approximation of household income. And so as you go from left to right, you can see lower income on the left. So we're looking at under 15,000, 15 to 19,000, and so on. And on the far right, we get to some of the higher income brackets, the 200, 300, 400 plus household incomes, our approximation of household income. And what you see is pretty interesting to me. The higher income population, specifically the 100 to 400 per $1,000 per year of households, we see the biggest impact, 35–40% decreases in wellness utilization in those populations. The lower income populations, a markedly lower abatement results. And some of that could be location, we'll talk about that. Some of that could be ethnicity and things like that. We'll talk about some of those. And some of that could be what type of work are you in? And is there access to care? And is there an anomaly as far as your ability to get to the doctor legitimately anyway? So let's take a look at ethnicity. We know that there's real disparities in healthcare across the healthcare system. COVID, again, has shined a light on that from a prevalence perspective and a mortality perspective. It also has created some interesting dynamics when it comes to the reduction of wellness visits. So as you see on here, and again, this is our approximation of ethnicity of the membership. And so we see that a good majority of the ethnic groups, we see the 30–35% reduction in preventive or wellness related care. But the interesting part is on the right-hand side, you see a couple of populations, East Asian, Eastern European, where we saw a significant reduction, approaching a 50% reduction in wellness utilization. Some of that potentially is going to be market driven, where those populations are maybe located in the Northeast and the West and things like that, potentially driving that. Some of that's going to be culturally, some of that's going to be just how those cultures, have dealt with this kind of pandemic and what sort of steps they've taken to protect themselves as well. And then we thought it would be interesting to start to look at some of the geographics. And again, I can't stress this enough. As you've seen in the maps, the Johns Hopkins maps and so on, COVID is definitely geographically specific in how it's impacting our society. What I would say as you look at some of these maps is these are going to be a bit different than where you see the highest incidence of COVID. The reduction of wellness visits, the reduction of vaccines and diabetic care and things like that is really attributed to those states, those communities that shut down. And how quickly did we shut down? How quickly did the healthcare system shut down, and how quickly did they come back online? That's really what this is going to focus in on. So for example, on this view, we're looking at wellness utilization and how the wellness utilization has changed in the different states across the United States. You can see the legend on the left-hand side. Some of the lighter colored states, we're seeing 20% or so reduction in wellness utilization. And when you get into the dark blue, we're approaching a 50% reduction in wellness utilization. Same time period, same populations. So for example, I live in Minnesota. If you can't tell by my accent, hopefully not. But if you look at Minnesota, we are a dark blue. And if I were to show you a map of where COVID kind of spread and where the COVID rates are, Minnesota turns out to be pretty good. I'd say at least average, if not below average, when it comes to COVID actual prevalence. But we shut down really early. The healthcare system here shut down pretty early. We stayed shut down a little bit later than other states. You can see our neighbors to the west, the Dakotas and Iowa and so on, the shutdown was very different from a government perspective there. So our impact in Minnesota specific to wellness is more dramatically felt. Here in Minnesota, you can see in California, and you can see on the East Coast, as those states locked things down a little bit sooner than others, you'll see abatement have a bigger impact. The next page we'll look at, we'll scroll through a few different views of the different types of screening. So mammographies, a little bit more even color. There's a little bit less extreme, I'll call it. But again, it focuses in on those states that shut down. Michigan, Minnesota, California, and basically all of the Northeast. That's where you're gonna see a tremendous impact on mammography compliance or screening rates so far. You'll notice the South, that we're seeing a dramatic less of an abatement, still an abatement. We're still talking 30–40% reductions in mammographies, but very different from counterparts in the Northeast. And now we'll look at cervical cancer, same sort of trends. It is interesting that some of the states that do a little bit worse for mammographies and wellness visits, they start to pop up for some of these. So some things folks weren't able to wait for and were able to get into more readily. So for example, in the South, some states start to pop up. Tennessee, for example, starts to pop up as doing a little bit better for this when they did a little bit worse when it came to mammography and wellness utilization. You can keep scrolling, David, if you want. Let's talk a little bit about chronic disease. So managing high cholesterol, lipid panel, cholesterol screening, things like that. Basically the whole South, you can see moderate declines, still declines, but moderate declines. You look in the Northeast, again, look in the Midwest, more significant reductions of care as far as managing chronic disease. Scroll back to a cancer screening again. So colonoscopies, something that we as a healthcare system struggle to get members to use anyway. And now we have a bigger problem. We're seeing in some of these states, almost 80% declines in colonoscopies during this time period. Really challenging for a procedure that we struggle to get people in anyway. Add COVID onto that, add abatement onto that. It's going to be a challenge to get these numbers back to where we'd like them to be by the end of the year. And it goes beyond that. Again, chronic care, very similar to what we saw for the lipid panel screenings and so on. The Northeast issue, Midwest issue, South doing a little bit better. Tennessee comes in and out. They're doing a little bit worse for diabetic care. It goes beyond just chronic disease, cancer management. This gets into what are we doing for actual prevention of within kids and vaccinations and things like that. So tetanus shots, you can see on here, in some states, 50–60% reductions in people getting tetanus shots. Obviously something you can catch up with, but we need to, otherwise we're gonna face some significant issues around whether it's tetanus, and we can jump into the next one as you jump into other vaccinations of measles and chickenpox, the same sort of issues. So here's a view of diabetics and looking at the hemoglobin A1C tests that are being done. The Northeast, dark blue, rapid reductions there. You can keep it going ahead, David, if you'd like. And then if we even look at measles vaccinations, so let's hope we don't have a whole different pandemic on our hands with an outbreak of measles, but some of these states, 70% reductions in kids getting their measles vaccinations. So New York, for example, seeing significant reductions there. And it goes, here's another way of looking at a different view of the measles vaccination. And then if you flip to I think the last map we have, David, looking at chickenpox. So as we see this, and this is obviously impacting primarily children, there are some states, New Mexico, for example, where it's a 40% reduction in our ability to get kids in to get vaccinated for chickenpox. Does this change? Do we see this start to come back, and how quickly is going to be a critical factor? And what do the next couple of years look like? So just to kind of wrap that up, we talked a little bit about some of the tailwinds. The headwinds are pretty clear. We saw a significant reduction in preventive care. We're doing everything we can as a healthcare system. David's going to talk a little bit about what he's been doing. From a UnitedHealth Group perspective, we're recognizing all these gaps, and we're doing everything we can to guide and nudge and communicate to those members around getting back to health. If we don't get on top of this, it's going to be a long-term sustained issue. There's going to be less cancer found. There's going to be diabetics that are going to be non-compliant for now 6, 12, 18 months. This isn't something that we're seeing a quick bounce back to yet. Of course, we don't have a vaccine out there yet, and people aren't all back to work, and everything isn't opened up yet. Maybe we see a bounce back at that time. But the data is telling me as a non-clinician that this is going to be a slower return back to preventive care than we would like. And I think it's a real call to action for all of us to really focus on these type of metrics, because if we don't, COVID is going to have a longer term impact on the healthcare system around the morbidity that we see associated with that dramatic reduction in preventive care. And with that, I'll pass the ball back to you, David.
Thanks so much, Craig. This is really interesting, and I know you're just at the beginning of this effort to try and help everybody understand, United's clients understand what to expect. But Craig's data really provoked us at EHE Health to start to look at, what's going on with our population, and as most of you know, we spend a lot of time and energy trying to get people in for their preventive health visits. And it looks like, and there's more to come on this, we did a first cut of what was really going on from May to September. It looks like we are bucking the trend a little bit by getting people back, not to incomplete levels, but potentially to greater levels than what United is seeing in the general population. And so this is a chart that shows what's actually happened in our patient population from May through year to date, which is September 16th, by month. We look at this in two ways. We, our team, we have an omni-channel health marketing platform and a whole bunch of people that reach out with the help of our employer clients to people to bring them in. And we look at one thing, our bookings, and then we look at the complete visits or encounters that are done. So we tend to book more, and then there's cancellations and rescheduling and the like. And as you can see, obviously, we were shut down and closed for most of May. And so that was a dramatic reduction. And we opened up in the last week of May. June started to tick upwards. We frankly beat where we thought we would be in July. We actually saw more bookings from a year over year from 2019. Came to about even in August, and so far in September, we appear to be ahead of where we were year over year, in other words, for last September. So that gave us heart that we're kind of trying to do the right thing, and that maybe it's working. And I say this is raw data. I don't want to represent that this is independently analyzed or the like. This is what the raw data we're seeing. And so obviously we try and create hypotheses about why this is happening. And we came out to essentially three. One was COVID-19 status. We have been offering COVID-19 tests to all of our patients, and there is an interest in that from our employee populations. This issue about COVID-19 comorbidities is real. People see it on television. They understand when they're at risk, and we have communicated to them these risk factors. And we find that this is an important area of discussion and review when they come in to see our own providers or network providers. And then, of course, there is this feeling that people are on their minds is they've missed their preventive health visits, and they are cognizant that it's something that they should keep up. So thanks to the efforts from Craig and United, we did take a look at our business, and in summary, we think we're on the right track. And I want to say this in a positive note to all of the employers on this call, that just because we've seen some pretty difficult data for a nation as a whole, I want to give some encouragement that I think that we can do something about it. And I think that it really is incumbent upon all of us to try and do what we can, because I think that if we don't, we really are looking forward to some big problems in 21, 22, and 23 that really are going to be the sequelae of this pandemic once the infectious component of COVID-19 is passed. So with that, I'm going to stop sharing the screen and see if we have any questions here, which we do. But I think I would like first to ask Craig some questions. And a question, I don't want to put you on the spot, and it has to do with economics. as it relates to healthcare spending. We have most of our clients are large self-insured employers. And clearly, United and other carriers have reported a significant loss ratio reduction, over the period of the pandemic. And what's the forecast for employer spending for the rest of the year? And understanding what we're seeing here with respect to the abatement issue, what does that mean? I know you can't be specific and you don't have a crystal ball, but what do employers, what should they be watching out for in 21, 22, and 23 as it relates to all of this?
Well, I would say just a couple things to consider as we look at healthcare cost and utilization. We are seeing that the second half of the year, things are, I'll call it, returning to normal, sort of. So we haven't quite caught up to prior levels, but we're normalized or getting close to that as a healthcare system, and we're experiencing some of that. So not quite back to normal, not quite back to the catch-up period that we talked about, but at least returning to normal. So we're expecting that that's probably going to play out as we get to the second half of the second half of the last quarter of the year as well. The big unknowns and the things that we're really planning for and strategizing around is we're all focused on the vaccine, right? How is that going to be administered? What's the cost associated with that? Who's going to bear the burden of that cost? What is that going to look like? As well as what is the morbidity look like associated with some of this reduction of care? Is there something from a trend perspective that we'll start to see in 2021 and 2022 and beyond if we don't catch up to some of the care that we're seeing here as well? So a few key variables as we start to get our arms more firmly around the actual prevalence of disease and the mortality and the utilization associated with the disease itself. Now focused on how do we get out of this? What does that cost and experience look like? And what does the return to care look like as well?
And you have no idea yet about what that change in utilization is going to be, or what employers should be planning for as it relates to healthcare budgets and the like.
I think we're all assuming that once we start to stop the spread and potentially have a vaccine at some point in 2021, we hope that at that point you're going to see a return to care. To what degree is the debate. We expect that there will be increase in services and increase in cost, and a lot of good costs that we need back in the system with preventive care and so on. But we don't know the extent of what that return looks like or what that catch up looks like quite yet.
Okay, great. So question here is, this is a really interesting presentation. This is for you, Craig. People want to know, I see this is being recorded. Will this be available to participants after the seminar? And yes, this will be on our website. So this is a fully recorded presentation. It will be freely available to everybody. And we thank, again, Craig and United for doing this with us. I have another question here. With the psychological barriers that prevent people from engaging in their health, what has EHE done, or what would we recommend for employees to consider to help get them back to care? That's a really great question. I'll take that. So I think messaging is really important, and I think being factual, practical. This epidemic is not being spread in doctors' offices. It's not being spread in clinics. It's being spread in other scenarios. And I think that the most important thing to communicate to people is the safety of doctors' offices and of places of care. And once people are reassured, and these processes and these precautions are very explicitly described, people get more comfortable. The psychological issues that we are seeing are many. They relate to, frankly, in urban areas, what we hear a lot about is transportation and the safety of public transit systems. Many of you may remember a webcast I did several months ago with Jeff Shaman from Columbia, where he talked about the impact potentially of COVID spread in public transport, and he felt it was probably minimal. The data suggests that that is probably true. It's not risk-free. And frankly, wearing a mask and personal hygiene, cleaning your hands and stuff is probably quite sufficient to have a safe subway ride or a safe public transit ride to get to the doctor. We communicate that very explicitly. One of the things that we have found is the issue of essentially depression and people actually being home and not wanting to, being subliminally depressed and not really wanting to get out of their houses. As a pilot, several weeks ago, we added a psychological social worker into one of our clinics here in New York. One of our clients was pretty explicit. They surveyed their employees and they said, look, the biggest issue they're facing is loneliness and depression and difficulty dealing with issues of family, potentially homeschooling and all of that. And we decided as a test to put in a psychological social worker in our clinic. It has been a resounding success. Sometimes a physical visit is better than a Zoom visit, quite frankly. People want to talk to another human being. When we have discussed what we're seeing from a psychological point of view, the feeling is that the most important risk factor are those people who live alone and live in isolation. And I would say in these kinds of situations, what we're dealing with is potentially the risk of staying home and not getting out, whether it's to preventive visits or even back to work, may be greater from a psychologically detrimental point of view, and having a clinical illness clinical depression requiring treatment may be greater than in fact getting COVID. And so this is a complicated but dynamic balance that people have to consider. And I think we need to be open to all of that. So I think reassuring people on safety, making sure that they feel comfortable in a physician's office and that all the precautions are being appropriately explained in advance, I think that's really the way to get people out. So that was that question. Can I bring another question, Craig, for you? And we have talked about this, and that relates to the issues of how people are going to be changing their behavior differently. We talked about influenza, and you alluded to it. We have seen potentially a reduced incidence of influenza in the Southern Hemisphere because people are simultaneously taking care of COVID, which is obviously preventive for both respiratory illnesses. Do you think very specifically people's behavior is going to be changing in this regard with respect to our current flu season? I mean, we're all over trying to get people in to get vaccinated for flu. This is obviously an issue, but what does this mean after the pandemic? How do people start to treat these respiratory illnesses? And do you think that maybe we'll see a decline in the spread and a lot of the social stigma about wearing masks going away? And how are we going to behave in doctors' waiting areas and the like?
Yeah, I think that's going to be really interesting to track. And first of all, I'm not trying to compare COVID and flu. There are very different and very different results associated with them. But as you think about how we are handling COVID and what we're learning around protecting high risk, protecting the elderly, if you think back to a year ago, if we were struggling with symptoms that we thought were flu-like, we would go into a clinic and we would wait to be seen and be screened and return home and spend time with our family. So as you think about that kind of event and with a COVID lens on, think of the amount of people that we were putting at risk through doing it that way, through that old way of kind of thinking around handling the flu. I'm not sure what's going to happen, but I could definitely see us starting to implement some of the policies and procedures that we have put in place to protect people against COVID to start to protect people against the flu. We shouldn't have a patient that's struggling with the flu sitting in a waiting room next to an elderly diabetic patient that we know has higher risk if they contract that disease to potentially have greater morbidity associated with that. I think we're going to learn a lot from COVID and start to apply that against other infectious diseases such as the flu that will greatly impact the mortality rates that we see with the flu on an annual basis. No one really knew, no one really talked about the fact that many people die from the flu every year. But if we start to implement some of these policies, like we did with COVID, personal hygiene, potential masks, quarantine, and even how we handle people in provider offices, there could be a unique way to help reduce long-term impact of flu in the country. Even as much as drive-through screening and tests when it comes to COVID. What if we did something like that for flu rather than waiting in a waiting room? What if we had things like that to test for that versus having to go directly into a provider office? So just things that I'm thinking about as I think through the analytics. If those sorts of things we think are making a substantial impact on COVID, I think they could also make a substantial impact on what we see with flu as well.
So I guess in summary, it won't be so much of a stigma maybe to call in sick when you have flu, maybe in a year or two.
Yeah, you'll never be seen as tough.
Hopefully, your employer will
anymore.
They'll probably make you work anyway because you'll know how to use Zoom and all these other technologies.
I was going to say that now that we all can, you can see where I am. Now that we all can, maybe we'll be a little more flexible when we're not feeling well.
Okay. This is a question for you, Craig. Have you observed any reductions in prescription drug therapy associated with chronic conditions like diabetes, high cholesterol, hypertension, especially for new patients prescribed such therapies after having been identified in a preventive or primary care exam? In other words, what's the drug utilization doing around all of this?
Yeah, what I would say is that we actually are not facing a similar issue on the pharmacy side. And a lot of that's due to the fact that early on, as things were starting to shut down, a lot of members received their prescriptions a little bit early. So they were able to get their prescriptions and even continue to get the prescriptions from a mail order perspective and things like that. So we have actually seen an increase in utilization on the pharmacy side as people start to leverage those kind of benefits to stay compliant. The question specifically on new patients, newly diagnosed patients, and their adherence, there's going to be two things that are working against there. First of all, there's less people who are newly diagnosed right now because they're not going in to be screened and be checked. When they are going in, we're not seeing that their pharmacy adherence rates show a dramatic difference than what we've seen historically, especially with all the ways that now a lot of the retailers are open in a safe way and mail orders readily available. We're seeing that utilized at high rates as well. We're not seeing this as big of an impact on the pharmacy side.
Super. The next question is, it relates to the disparities, which is they're really just pointing out, if you could dive down a little deeper, there really was a gap on two ethnicities, one being East Asian and the other being Eastern European.
Mm-hmm.
Do you think that's just where people happen to live and where there's lockdown, or is there something cultural that you've seen in utilization in those populations pre-COVID as well, or you don't look at it that way?
I would say yes to both. I think it's, first of all, the primary is going to be impact around where you live, what state you're in, lockdown, reopening, all of that matters is primary. But as we're learning more and more and analyzing, I'm spending more and more time analyzing disparities in healthcare, especially from a race perspective or ethnicity perspective. We know that there's lots of barriers, and culture has a lot to do with it, as well as access and income, and all of that matters a lot. So have I been able to delineate exactly which variable in those ethnic groups are driving this? I haven't. We haven't gotten to that kind of detail yet. So I think it's a combination. And as we look at anything in healthcare, I think we have to start to put our shoes in the feet of the patients we're hoping to treat, and understand that ethnicity and race and income and bias and things like that really matter. And we need to start to figure out how do we, if we're going to engage some of these populations that are struggling with access to care and things like that, we need to start to understand more of the why rather than blaming, more of the why, and how do we start to help and prop up some of those populations that really need a different way to access care, unique based on some of the sensitivities.
Okay, great. The next question is, what can employers do to encourage their employees, our employees, they say, to get their preventive care back on track? Is there a, quote, jumpstart that process would you suggest for folks to do? In other words, I mean, you have a huge client base. I'm sure, you know,
Yeah.
what are people doing basically?
I think first of all, we are naturally just communicating to everyone broadly across the whole population of UnitedHealth Group. We're doing a lot of those kinds of things. But from an employer perspective, the best way that we've historically found, and I think it's going to play true in the COVID season as well, is if you can make sure that it's a coordinated effort and it's really communicated in the right, most sensitive way. I think making it a celebration is not the right word, but a momentum sort of building atmosphere that we're in this together and we need to focus on this for ourselves and for the company. Those are the types of communications and efforts that we see work the best. Leadership buy-in always helps as well, but really emphasize this and make sure that this is top of mind. It's not something that we're just going to forget about in a year. We'll start to deal with. This has to be a major coordinated effort with the payers, the providers, and the employers coming together to all focus on this so that the patients and the employees are hearing a very consistent message around the safety of getting that care and the necessity of getting that care. Otherwise, there'll be further issues that we'll face.
Yeah, I'll just say for us at EHE, particularly in the urban areas where the concern is mass transit, when people vocalize that concern, I mean, we have a program where we have coupons, you know, for Uber or Lyft or whatever, you know, they're not expensive and it's really worth the effort, you know, to get them in. And sometimes it only just takes once for people to get out of the house and to feel comfortable, and then kind of the tension eases. So, you know, for the person who asked that question, I mean, to really understand what the issues are in a geographic base that are preventing people you know, from coming in. And I think you'll need to have a customized solution based on the demographic and of the population, as well as the geographic of the population. And, you know, one thing we know that, you know, the stage of the epidemic is different in different parts of the country. And that counts for a lot in terms of people's anxiety about whether they want to come out or not. So looking at the are not factors of transmissibility and where they are in that regard, I think is really important. What is Craig's opinion on the impact a vaccine will have on the pandemic and the way in which employees will begin to engage in healthcare? Well,
that's a tough one. First of all, we have to have a vaccine. I think that it will, if a vaccine is made available and it's effective, I think we're going to, first of all, face issues around making sure that we get high levels of society to be vaccinated, first and foremost. If that happens and everyone's feeling more safe around that, I think we will see a little bit of a rebound around some of this. I think that a portion of the population will feel safe and come back to care, and we'll see a return to normal, or maybe even a little bit of a catch-up period at that time for that population. But again, I do think there's going to be, I don't know what the numbers, what the percentage is, but I think there's going to be a portion of the population that's psychologically, even with vaccination, even with everyone saying it's all safe, that is going to face an additional barrier to return to care.
Look, I feel I have to add something here, which is that as an epidemiologist, way before even COVID, this whole idea of the anti-vax movement, which by the way has been around for 100 years, this is something that employers can really step up and help with respect to the communication of objective facts and scientific evidence. You know, when a safe and effective vaccine becomes available, is approved by the FDA, I assure you that I'll be first in line for my risk group to take it without any doubt. I personally can envision a time when, to ensure workplace safety for a safe and effective vaccine, that could be a mandatory thing, or something at least employers are going to want to insist on. You know, I think employers have a real role here to start separating out fantasy from fact about what vaccines are about and what their safety is, and to encourage people to kind of follow good scientific guidelines. That ultimately it's not going to be only great for them, but hopefully it's going to affect the baseline immunity of a population and reduce transmission in even a bigger way. So I would say to that questioner, yeah, a lot of its impact is going to be on how we talk about it and how we convey the evidence about it, how we introduce it, and how we continue to communicate about it. And frankly, I think there's a lot to be desired in that regard. And I'm a big believer that, frankly, not only employers, but large doctor organizations and like need to start speaking up about this. I would also like to say, in addition, that I think there are two other technologies that are coming down the path. I think within the next 4 to 8 weeks, I think we're going to see some approval, hopefully, of some antivirals, effective antivirals, particularly monoclonal antibodies, which can be useful in treatment early on, which would have significant impact, and also the advent of cheap and effective testing. Which imagine having an immediate test, which is, people are talking about a $5 test that immediately separates those out who have, who are asymptomatic carriers from not. The combination of a vaccine, a dramatic improvement and availability for cheap, effective, immediate testing, as well as antivirals, I think really could have an impact as early as the first quarter of this year. So I keep my fingers crossed personally, and I'm banking a lot on bioscience brains in this country and innovation to help us get through this. If the amount of COVID cases increases as the weather gets colder and people are inside more, will reductions in preventive care actually get worse? And how bad could it get, Craig?
Well, I would say if there is another, we are, like you said, Dave, we're starting to see nationally a bit of an uptick. If COVID starts to spread again at the rates that we saw in the March, April, and even the summer time periods, there's potential that some communities have to go revert and start to shut down to some degree. And if that happens, then we'll be in the same boat, and we'll face the same barriers that we face today. I don't know if anybody's really anticipating that to get to that kind of level, given everything we know now and the types of treatments and things like that that are available around a full shutdown of access to care. But that's always a potential, given what we'll see what happens in the fall here.
So I have a question for me, which says, is it possible that this pandemic can become worse, or is there something positive about the future? Well, I indicated what I thought was positive around the future. Actually, I get asked this by my board of directors all of the time. And some of our large clients, as many of you know, we provide a safe at work program for COVID. And I think we're walking into a big 3 months of uncertainty where people are going back to school. We're seeing increasing rates of community spread, albeit, yes, it's in younger people with somewhat lower mortality. The aggregate mortality appears to be in the 800 to 1,000 person per day, which is not good. So yes, we can see a rising incidence. Yes, there are issues with now in the Northern Hemisphere being more indoors. I can only say that, you look, I was reading yesterday, you look at a country like Italy compared to, for example, Spain and the UK, which Italy has remained pretty low and pretty flat. And people have looked at why is that? And essentially people feel it's because there's a leadership and community adherence to great, again, public health 101 tactics, everybody wearing masks, everybody doing personal hygiene. And so, for that questioners, so much of it depends on our own behavior. And here again, I think employers have a tremendous role to play by conveying factual evidence to help people get through this because, it's really the facts and the science that count here, and they do have impact. So I think we're going to have a pretty complicated few months, but I'm crossing my fingers. I hope we're going to see some important vectors of change, hopefully by the end of November with respect to testing, antivirals, and maybe even early vaccinations by December. And again, I have no evidence to support that that's going to happen. I'm crossing my fingers and hoping, however, hoping that it will, combined with improved public health measures. This is for you, Craig. Decline in vaccination, what worries you most?
Yeah, I would say
childhood vaccinations.
Yeah, I'll break the preventive care maybe into two buckets. And in the short term, the biggest impact that we're going to feel is going to be on the chronic disease. So, for example, managing your diabetes and things like that is going to be the most immediate impact on care and cost in the healthcare system. If that doesn't get fixed very, very soon, that's going to increase costs pretty quickly. And obviously impact the health of those members and patients. Longer term, my biggest fear is really on the cancer screening piece of it. That we have a little bit of time to catch up on those types of screenings, but again, if we don't, we are going to see a reduction in identified cancer until it's really, really bad. And so we're going to start to see some more extreme, more late stage, things like that. That's maybe my more long-term impact is around the screening rates.
That's super. And I have one last question, and it's right up to the top of the hour, so it's perfect timing, and it isn't a question. It's an exclamation point statement, which was to you, Craig. This was really great. The data is impressive and helpful for us as we plan for 2021. And I can't reiterate that strongly enough from
Thank you.
one of our clients.
Happy to help.
We all really appreciate it. And I hope you'll come back and we'll do another one when we dig down even further in the data and we come to understand exactly what we're up against. I think this is an important issue, not just for all of our employers and their beneficiary health, but it's really an important issue for planning as we go into 2021 and 2022. So thank you very much. This, as I mentioned, this is recorded and available on our website, ehe.health. And we have a hotline, continual hotline, and all other mechanisms to reach us if there are questions. And thank you, everybody, for taking the time this afternoon to spend with us to talk about this issue. And we'll let you know on when our next webcast is scheduled. Thank you again, Craig, and thank you, everyone.
Thank you.